Well, good evening, everyone, and thank you for joining us tonight. For those of you who don't know me, my name's Peter Field. I'm the State Manager for TDSA here in New South Wales. And on behalf of TDSA and the Respiratory Dental Institute, I welcome everyone here tonight. I would ask that, well, I was going to say we should probably mute our computers, our microphones, but given that there's only six of us at this stage, perhaps we leave them unmuted for the time being, but we will take questions at the end of the session. So our very special guest tonight is Dr. Edward Nguyen. Edward is an oral maxillofacial surgeon. He is an Australian, New Zealand trained registered oral and maxillofacial surgeon. He enjoys practicing the full scope of oral and maxillofacial surgery, including removal of wisdom teeth, surgical extractions, and dental implantology. His subspecialty interests include management of head and neck tumours, maxillofacial trauma, and corrective jaw surgery. Edward, could I just start by asking you how you became involved in surgery for obstructive sleep apnea?
Well, firstly, I'd like to thank you guys for inviting me on here. It'd be nice one day to do a face-to-face. In terms of OSA and orthognathic surgery, I guess I've always loved orthognathic surgery. Like, it's a beautiful operation and the outcomes are basically immediate in terms of the functional and cosmetic change you make to someone's face. And then I've fallen in love with the concept of the same operation for obstructive sleep apnea, because the cohort of patients who come and see you are different, where they're not 16-year-olds coming from the orthodontist because they want to change the shape of the face. It's basically a life-saving operation for them, and it's rewarding and it's challenging because it is harder to operate on older patients. So it's an area I'm definitely interested in, and it's still growing, and it's, I guess, not, there's a lot of evidence to support it, but it's not widely accepted yet. So I guess these sort of forums are good for me just to expose people to what we can offer in terms of sleep apnea, with the potential to cure patients. So yeah. Brilliant.
Well, Edward, with that, I will hand over to you, sir. And thank you once again for taking the time tonight to be with us and share your knowledge. Thank you.
Cool, thank you. All right. So just a bit about what the specialty is. Some of you may or may not know. It's a fairly lengthy, rigorous sort of process to get to the end. It involves 2 degrees in medicine and dentistry and several years of experience as a dentist and a doctor, and then 4 years of specialist training. So by the end of it, it's, I guess the scope of practice is very broad. You can kind of go into whatever area you want, but the bread and butter is dental alveolar surgery and implant surgery. And all of those, except for TMJ and pediatrics, are my interests. So I really love orthognathic surgery, head and neck cancer, and trauma. And I do a lot of that work out of in the public setting. So for me, I was born and raised in Melbourne, and I started my training in, did both my degrees in Melbourne, started my training in Melbourne, and then completed it in New Zealand. One of my biggest passions is head and neck cancer, so I did a head and neck cancer fellowship, and I'm lucky enough to practice that work out of the Austin Hospital. And I've kind of touched on that, but orthognathic surgery I love, but it's something that doesn't automatically come to you. So I'm lucky enough I get to do a lot of it in the public setting, and yeah, and I had quite a lot of experience when I was training as well. And I would say it's really more of a niche area, but as I said, it's life changing and potentially life saving sort of surgery. So I work between public and private practice, about half, and I've got a young family. Those are my 2 kids there. 3.5-year-old and a 10-month-old, and they keep me pretty busy amongst everything else. Yeah. So there, on the left is a photo of another surgeon, Roland Barrowman, and myself, and I call him Danny and he calls me Arnie. And we do a lot of our head and neck cancer stuff together at the Austin. And that's just a recent photo from with a couple of registrars and the charge nurse. And I also work at the dental hospital. So just a few things we're going to cover tonight about involves definitions, risk factors, and screening and workup of these patients. And I guess I've got a bit of a slant from a surgical perspective, just to see who's suitable to treat surgically or not. And it's fairly clear cut, and we'll go through that. And the role of MMA, or maxillomandibular advancement surgery, and the outcomes, and whether they're suitable and whether it actually works, and we'll talk about that. So obstructive sleep apnea, it's a breathing disorder, and it basically involves repetitive episodes of upper airway obstruction or airway collapse. And this leads to fragmented sleep and reduction in blood oxygen saturation. And this can have deleterious effects on the whole systemic circulation, your cardiorespiratory system, as well as the endocrine system. And we'll go through why they get, or touch on, I guess, what some of the manifestations are. So obstructive sleep apnea involves both apneas and hypopneas. And apneas are basically if you're essentially not breathing for at least 10 seconds. And hypopnea is where you've got more than 10 seconds with 30% reduction in airflow with either arousal to improve the airflow, or greater than 3% oxygen desaturation. And when you get a sleep study, we're interested in the AHI, or the apnea hypopnea index. And by definition, if you've got an AHI of greater than 5 events per hour, then that's considered to have obstructive sleep apnea. And so I'll just cut to the chase in terms of the role of surgery and orthognathic surgery. There is certainly a role for it in moderate to severe disease, and mild disease can be treated non-surgically. It is very prevalent. So, one in 4 males will have some form of OSA, and but it also affects females as well. Risk factors. So the ones that I guess I put at the top is anatomical, and they're things that can potentially influence and change. So if you've got any form of mandibular retrognathia, soft tissues, so do you have a large tongue? Do you have large tonsils? And if so, then removing them, the tonsils can potentially cure them as well. For example, I haven't talked about this, but OSA in a child versus an adult is drastically different, and more than 95% of OSA in a child is related to enlarged tonsils, and you remove them and you can cure them. In the adults, it's different, or commonly different. Reduce airway space, and then other risk factors: obesity, alcohol, smoking, and sedatives. So the morbidity, the complications, I guess, from obstructive sleep apnea, if it's left untreated, the issues with the heart and lungs are that you raise your blood pressure, increased risk of AMI, heart attacks and strokes, as well as pulmonary hypertension, endocrine effects in terms of increasing risk of diabetes, impotence in males, as well as depression. And you're 7 times more likely to get involved in a car accident from falling asleep. I can't even say Poisson's law, but it's I think it's a very relevant graph, and essentially your flow through a space is proportionate to the radius to the power 4. So it's exponential in terms. So if you can open up the posterior airway space by 2 times, then that's increasing the flow by 16 times. And that's relevant because all the pharyngeal muscles and the tone is all attached to your facial skeleton. And if you can move your maxilla and the mandible forwards, then you're opening up the airway space. And that's these 2 photos you can see, or the x-ray, sorry, you can see the dark shadow, which is your posterior airway space, is very narrowed in the first page, in B, and then in A, you can see in this facial skeleton, the airway space has been opened up significantly. So the factors that affect your anatomy are obviously I've touched on already: retrognathic mandible, large tongue, large tonsils, and reduced posterior airway space. So there's several studies have been done, and we know it's multifactorial and it's complicated, but Miles is a big proponent and done a lot of research on the role of cephalometrics in OSA, and basically found that mandibular length has the strongest association with OSA. So anyone who comes in with a big class 2 malocclusion and retrognathic mandible, then they automatically would benefit significantly from having jaw surgery. Obstruction, this is a key one. Obstruction is rarely isolated in adult, is rarely isolated to one level. So it can occur at the retropalatal level, retroglossal level behind the tongue, or hypopharynx. And retropalatal and retroglossal are the 2 most common causes of OSA. Positional factors, so people who open mouth breathers, that result in increased collapsibility of the airways. And obviously, if you're lying down flat, then you've got posterior displacement of the tongue. And yeah. So for GETA, this classification you may or may not be aware of, but this basically describes what I've talked about. So if class 1 is related to nasopharyngeal obstruction, class 2 is basically oropharyngeal or hypopharyngeal, basically, or retroglossal behind the tongue. And then class 3 is hypopharynx. So at the level of the basically, inferior to inferior pharynx. Common screening tools, 2 of them, the ones that I'm familiar with, are the stop bang and the Epworth sleepiness scale. Stop bang basically relates to, are you tired, do you snore, has it been observed in terms of breathing issues, blood pressure, increased BMI, age, and neck circumference as well as male. And if you've got a score of greater than 3 or more, then basically you're at risk and you qualify for a sleep study. Sleepiness scale is more basically when are you tired. So, you know, sitting, watching TV, etc. And that score is, if it's more than 10, then then also you're at risk of sleep apnea. Stop bang is probably more commonly used, and it's a slightly simpler system. So workup involves, you know, thorough head and neck assessments, and there's several different tests you can do. You can perform a nasoendoscopy to actually assess the airways, and there is a Muller's maneuver you can. I've never done it, but where you basically you can actually do it as a sedation type procedure or just in the clinic, and you kind of do a Valsalva, reverse Valsalva, and try and get them blow in and out and just see what's actually collapsing in the posterior airway space with the scope at the back through the nose, the back of the throat. Cephalometric analysis, I guess this is more historic, but it's useful to know. So if you've got a lengthened soft palate, reduced hard to mandible length, the actual mandible length, which is less than 70 something millimeters, posterior airway space, which is less than 9 millimeters, a high mandible plane angle, all these things put you at risk of OSA. But we now know that that's not as simple as that. Cone beam CT is more commonly used, and we can actually calculate their surface area as well as the volume of the airways, and PSG or your sleep study. So once you've done those things, for me, I want to know, well, A, does the patient have sleep apnea, and is it central or not? So obviously if it's central, then there may be a role for CPAP, but definitely not for surgery. If the patient's obese, then lifestyle changes are the key to drastically changing their sleep apnea risk, and they may not need anything further. And I also want to know how severe it is. Mild, moderate, severe. Is there an underlying skeletal deformity which I may be able to correct at the same time? And where exactly is the obstruction? If it's at 2 or more levels, like I said, then they may be candidate for surgery. So lifestyle changes, if you lose weight, then you can reduce your AHI significantly if you repeat the sleep study in like 6 or 12 months. And we know that CPAP is the gold standard. It doesn't matter whether it's 1 level or multiple levels. You're basically, with positive airway pressure, you're keeping the airway space open and reducing collapsibility. But while it's very successful, compliance is low because of a number of factors, whether it's dry mouth, partner disturbance, feeling of claustrophobia, being bulky, Mandibular advancement spleen, I won't touch too much on, but it can be very effective for mild to moderate disease, most successful in mild disease. And I actually have one myself, so it's good. It's good. Surgical options. So there are a number of soft tissue procedures. A lot of ENT surgeons will do septoplasty, turbinoplasties to open up the nasal passages. UPP is a very old procedure and still commonly practiced, which basically is to change the anatomy and essentially cause scarring of your palate and reduce the length of the palate and open up that that retropalatal airway. And it is successful, but the problem is the relapse rates are fairly high, and a lot of the at 2, 3, 4 years. And I guess we'll come back to that actually. Tonsils, adenoids, tongue reduction, jaw surgery, plus or minus genioplasty to bring the chin forward as well. Tracheostomy has a 100% cure in non-central sleep apnea, but obviously there's significant morbidity associated with that. Last one I won't talk too much about but hypoglossal nerve stimulation, there is increasing evidence to support that. There's been a lot of trials and can work very well in terms of essentially having a probe and a stimulator that will essentially basically shock the subconsciously, shock the tongue and increase the tone, help basically wake you up without waking you up. And it's successful in over 76% of patients in multiple studies. So surgical management. So the level of the obstruction will dictate the treatment. If it's a tonsil-related problem, sure, take out the tonsils. In Stanford, there was a Stanford protocol released in the 90s, which basically said everyone with OSA who's a surgical candidate should have phase 1 procedures first, which are basically soft tissue ones. And if they failed, then consider maxillomandibular advancement surgery. And the premise behind that was that, people think it's barbaric surgery. There's a lot of risk associated with it, and it was avoided. It was a last-ditch option. But the problem is, by the time they have the phase 2, they've undergone nasal procedures, UPP, tonsils, a lot of scarring. There's a lot of psychological burnout for patients as well, and then they're more reluctant to undergo advancement jaw surgery. So that's more historical now. So this is pretty key. This is basically who's eligible and who should have this. So anyone who's got moderate to severe disease, an AHR of greater than 15, if you've got documented hypertension and you've failed CPAP and there's cephalometric or cone beam evidence that your posterior airway space is less than 9 millimeters. Sorry, that's my kids. A multi-level obstruction, as well as a skeletal deformity, or you failed phase 1 therapy, then you should consider MMA. And you can see on this diagram, the palatal and pharyngeal muscles are all attached to the maxilla. Mandible, you've got the tongue, you've got all the super hard muscles. And if you're able to advance that, then you're able to open up this posterior airway space. We know that MMA has a very high success rate and can be a very successful alternative to tracheostomy. And there's two components to it, essentially. The mandible, we do what's called a bilateral sagittal split osteotomy. And all these muscles are muscles that we're able to advance away from the posterior pharyngeal wall, including anterogastric, malar hard, genioglossus, genio-hard muscles. And the second component is moving the maxilla forwards. And we'll come to how much we need to move forwards. And that's a Lefort 1 osteotomy operation. I've got a few pictures. And we're moving the palate forwards. We're advancing the palatal glossus. I'll leave it at that. So workup, basically, now this is what we normally do for a patient who needs orthognathic jaw surgery. You see an orthodontist, you see us, you have braces to align the teeth into a more favorable position and then do the jaw surgery, the remaining braces afterwards. That's only true if you've got some sort of malocclusion. If you've already got an acceptable bite, then for sleep apnea, you could actually go straight to surgery and I could advance your maxilla and your mandible by 1 centimetre and your bite would remain the same. So there's actually no delay to your treatment. But if your bite is unfavourable, then you may need a period of braces prior to having surgery. Everyone okay with that? Oh, the other thing I haven't mentioned there, you need a sleep study to confirm there is sleep apnea. And then a follow-up sleep study afterwards. Sorry, can you hear my son go nuts?
It's not too bad.
It's not too bad. If it's bad, I'll just I'll go close the door. Okay, so advances in our surgical technique as well as the workup for surgery has significantly improved the outcomes. So I'll just show you some diagrams in a second, but we're able to improve the precision to the millimeter, whereas how it was done 10 years ago or even 5 years ago was drastically different. I'm able to plan exactly where the cuts are to avoid teeth roots, to avoid nerves, make sure that the bone I'm choosing to put the screws in, which is all pre-planned, is into the best bone possible. And ultimately, we're minimizing operative time. Now, what was in the 1990s, this sort of operation took about 8 hours, an all-day operation. Patients would all end up in ICU. They'd be in hospital for a week. Often they're wide shut in recovery. The surgery is so refined now that a routine operation will take 2 to 3 hours. Normally 2 nights in hospital, a couple of weeks of swelling. You don't need to wire them shut. Not everyone needs to go to ICU. And for the majority of patients, they don't need the CPAP afterwards, although you still have it there. And transfusions are very rare, whereas in the 90s, nearly every single patient needed a blood transfusion. So there's still a lot of stigma associated with orthognathic surgery that it's not safe or that it's dangerous, but that's not true. And especially in Victoria, where we do so much of it, it's almost bread and butter surgery for for, like for example, I in New Zealand, we did so much facial trauma there that was bread and butter, and the average surgeon would do it exceptionally well, whereas the average surgeon in Melbourne may not do it as well because that's not a common procedure or not as done as commonly. Whereas orthognathic surgery in Australia and New Zealand is performed the most in Melbourne. And there's a surgeon in Melbourne who can do the two-jaw surgery in under an hour. So it's very refined now. So this is just an example of what's called a pro plan, where here you can see there's a blue cutting guide. Once you've exposed the upper jaw, you basically screw holes, you secure this, and then the red line's basically where you're going to do your bony cuts. And then once you split the maxilla, then these holes, which were already pre-drilled when you put the guide on, should match up exactly to a plate, which already shows you how much you have to advance the maxilla forwards. And if you have, it only fits into one spot. So if you plan to move it 8 mils or 10 millimeters, it will basically only fit once you've dragged the maxilla 10 mils forwards. And like I said, the plan already incorporates, if traditionally you'd be like, measure 5 mils above the apex of the canine, make sure you haven't drilled into it. Whereas here, this is all pre-planned, so you don't have to think about it. This is essentially a concept that the incision is all done from inside the mouth, and we use either a saw or a burr to section the maxilla, and then you've secured it with plates and screws in the new position. The bilateral sagittal split osteotomy is the lower jaw surgery, and again, it's split along the length of it because to avoid damage to the inferior alveolar nerve, and you advance it basically to match the maxilla. So most people do maxilla surgery first, then mandible, and then you basically have to advance your mandible to bring you into a class 1 occlusion. And the standard is try and move everything as far forward as possible, but if you can do it, 10 mils in maxilla and the mandible is the ideal, and that's been shown to give you the best success rates. This is just a case study of a patient who had severe OSA. He's a big stocky guy, non-smoker, not really a drinker. Wife was ready to leave him. He's always tired, falling asleep in the car. And he had a fairly lengthy history of having a previous UPPP. He had a geniotubercle advancement surgery, basically to move the chin forwards, and the geniotubercle, which has the tongue attached to it. Found it helped initially, but then the snoring and the sleep apnea essentially relapsed. He'd tried an advancement splint, but he couldn't get enough advancement without causing pain to his teeth, and he just couldn't tolerate CPAP. So based on the Stanford protocol, he's failed all phase 1 treatments, and so now he's up for MMA, and his sleep study demonstrated that they're all obstructive apneas. So he underwent a period of orthodontics, and you can see he's got an underlying class 2 skeletal and dental malocclusion. So he's got a retrognathic mandible, he's got a reduced chin to throat length, okay? And you can see he's class 2 because he's got that pronounced labiomental fold. It's almost folded in half, which is very classic of a class 2 skeletal pattern. And it's probably more prominent because he's actually had a chin operation in the past. So he's undergone decompensation, which means we're able to move the mandible more than we can move the maxilla, you'll see. So he's bimaxillary intrusive. So he's, if you look at his cephalometric analysis, his A point is slightly behind the norm, and his B point significantly behind the norm. And regardless of what his Kephrometric analysis is, we always try and advance it as much as possible. So he ended up having an 8mm maxillary advancement and 18 in the mandible. And with such a big gap, he ended up having a hip graft bone to make sure there was bone-to-bone contact. You can see on the Keph analysis here, the LAT-CEF, sorry, is pre-op versus post-op. So everything's brought forwards. And I guess the most pertinent feature from both these x-rays is if you have a look at the posterior airway space on the pre-op versus the post-op, it's more than doubled. And this patient was essentially cured. Cosmetically, you think moving someone's face 18mm forwards, yes, it's changed the shape of his face, very subtle though. And there's been quality of life studies done on this type of surgery for OSA, and patient satisfactions in terms of the facial appearance was over 95%. So less than 5% of patients were unhappy with the face afterwards. But like I said earlier, I'm doing this surgery to save their life, not for cosmetic reasons. But obviously, they have to be aware that there is a change in the facial appearance. But he looks pretty good. So he had a pre-operative AHI of 60 and post-operative 4.9, and
wow.
that is a cure. So anyone under 5 is cured. And overall outcomes, his wife's much happier. He's not snoring. He's not waking her up. Doesn't need the CPAP. His own energy levels are great. And the only downside that he reported was that he couldn't feel the left side of his lower lip, which is one of the known risks of the lower jaw surgery. And in someone in their 20s and 30s, the risk of damage to the nerve permanently is about 10%. In someone 50 plus, then that risk will increase significantly. But there's no patient I have known who wished they didn't have the surgery because of a numb lip. It's sensory, not motor. The facial appearance looks the same. So there's a lot of evidence. There are a number of meta-analyses that have been done. Holt is a good one, and basically cure. And they found if you're able to move the maxillomandibular complex greater than 10mm, then that led to the high success rate. Success rate basically means a drop in your AHI by more than 50%, and I think it's, I've got to look it up again, but I think it's less than 20 in total, whereas cure obviously is less than 5. So success rate is very high. It's near 90%. Cure rate is near 40. Now, doesn't mean it's not working. Like you may be going from an AHI of 60 down to 10. That's still life changing for a patient. From pretty much majority of them, bar a few, that you can ditch all the adjuncts and CPAP. The predictors for success include anyone who's thinner, who's younger, and has a low AHI. So if you've got an AHI of 100, then it's very hard to cure that patient. This is a good one, a study in China that looked at 600 patients, success rates again very high, and cure, and which was very high actually. More than 60% of them had an AHI of less than 5 at the end of it. If you're able to move them forwards by more than 8, if it was under 8, then the cure rate was at 30%. I don't think there's another study that has been able to mimic that, but there's still very good results in 600 patients. Essentially, the summary is that patients are overall happier, improved quality of life, reduced symptoms, and objectively reduced apnea-hypopnea index. So in summary, MMA can be the first treatment of choice. If you've got moderate to severe disease, if you've got disease with an underlying skeletal deformity, and if you've got 2 or more levels involved, and someone who can't tolerate CPAP, then they're all worthwhile considering in orthognathic surgery. And rather than the other gentleman I've just shown you, you can avoid multiple surgeries if you know this is the case, because a lot of them burnt out and they see it was a last resort. But the point is that we may be able to offer something as a first protocol. So we know that OSA has significant health consequences, and CPAP is certainly still the mainstay of treatment for most patients. And orthognathic surgery throughout the world is certainly playing more of a role, and the treatment is changing. We know that the short to medium term results are excellent, and even some of the longer term studies with more than 2 years follow-up show that it's proving to be a stable operation with stable outcomes compared with, for example, UPPP, where arguably the patients are very sore, don't eat, lose a lot of weight, AHI drops, and then 12 months later they put the weight on again and they relapse. Look, the same thing can happen with orthognathic surgery, but anatomically, we're putting them in a more favorable position by moving everything forwards. Phase 1 therapy should really be limited to specific areas of obstruction. For example, if it's the nose or tonsils, for mild to moderate disease only. And long-term studies are being published, which, as I said, show favorable results if you're moderate to severe disease. And that's it. I don't know if you know how long that was.
Edward, that was great. That was nearly 45 minutes. Brilliant. Thank you. I loved the case study. I'll just take the screen back if I may. And I thought I would open it up for questions. We've had a few people join us since the start. So if you would like to unmute and you have any questions, please go right ahead.
I think I'm going to start here. Thanks, Eddie. That was great. Just very quickly, does a high arch palate preclude actually advancing it forward?
No. No. Like if I'm just trying to think of syndromic patients with high arch palates. No, it definitely doesn't. It just means that the where you do the osteotomy is probably going to be a bit higher up. But I've had pretty good experience in cleft orthognathics, which is probably the most challenging surgery or patient cohorts to treat, where you're often dealing with two separate maxillae, which haven't fully fused with bone. But high arch palate is certainly not a reason why you can't have the surgery. Yeah. Can't hear you, Stubbsy.
You need to unmute, Michael.
So everybody knows now. I know not how to unmute. Can you hear me now?
We've got you, Michael. Yep.
Oh. Eddie, that was great. I was going to ask you too, before you contemplate orthognathic surgery, do you entertain the idea of having a form of, say, a mandibular advancement device that at least the patient can have a PSG done to see? I appreciate you can advance it even further than they can advance, but is there any role for a mandibular advancement splint with a PSG sleep study being done before surgery, before contemplation of treatment, to see if in fact advancement would be, effective?
Yeah, I think there's definitely a role. I think we know it works. I reckon where it may be beneficial is if you've got a patient who's unsure, and if you're able to prove that their sleep study has improved by, with an advancement splint, then and for me, I'd be able to say, look, here's the evidence. I'm fairly confident I can improve that significantly more. Let's say your advancement splint brings them forwards 6, 7, 8 millimeters, but I know that I've moved a mandible 15, 18 millimeters, so it can happen fairly easily and safely. But I think that's just an extra armamentarium we can use to, especially if we're working in a multidisciplinary setting, just to prove that it works. Yeah.
Okay, thank you.
Any other questions from our registrants tonight?
Yes, hi guys and gals. It's Deborah Sykes. So I've got a question about class 3 skeletal patterns with OSA. So what are your surgical options there?
Same thing. So I would they'll need a period of orthodontics. I'll decompensate the patient and then aim to bring them into a class 1 occlusion, but still advance the mandible as well as the maxilla. So for example, if they've got a reverse overjet of 3 millimeters, I would aim to advance the mandible at least 8, and then the maxilla may move forwards 12. That's challenging but possible. And that way we get them into a class 1 pattern. And we might find that the obstruction may be predominantly at the retropalatal level, in which case your bang for buck is in moving the maxilla forwards. So in that setting, I would never, if it was for a cosmetic procedure, then it would probably be balanced movement between moving the maxilla forwards and mandible back a bit. But in the setting of OSA, I would aim to move both forwards by something. Yeah.
Okay.
Thank you, Deborah.
Thank you, Peter.
Any other questions tonight, guys, ladies?
With all of these treatments, the underlying first portal is weight loss. So how much therapy do you embark on with a patient to do weight loss before you would embark on a surgical treatment?
I think that's I think it's a really important, a good question. And as a surgeon, I think the biggest mistake you can make is just jump into surgery. And especially with my background, like it's a deflection here, but background to head and neck, it's head and neck surgery is all about involving so many disciplines, and something might be really important to them, such as their ability to eat, right? And I'm more interested in curing them, get rid of the cancer. So that for me is like, well, I have to involve the speech pathologist, have to involve the dietitian. So with OSA, it'd be the same thing. If obviously if they're not their normal BMI, it's different. But if they had a BMI of 30 plus, then it's something I would heavily emphasize. If they had an underlying, if there's skeletal, there's no obvious skeletal discrepancy and it's just weight, then I wouldn't necessarily offer that as an option to treat them, because maybe the weight loss is enough for them for the airway collapsibility to improve. In which case, let's say 6 months they lost weight, redid the sleep study, and it's still bad, then I'd consider it. But if it improved, then I'd probably hold off. Yeah.
So the reason I asked is I had a 18-year-old body mass index, young lady of over 50, 18-year-old, 120 kilos, and she hasn't had a dietitian talk to her, and works at McDonald's, and is a class 3 skeletal with just an edge-to-edge occlusion. A heavy grinder. So some of the basics haven't been started, and she's been referred for a mandibular advancement splint. But in an 18-year-old, I'd be loath to do that because she'd get irreversible class 3, changes. I think, even though it's an 18-year-old girl, she, you still get some changes at that age, certainly long term. So it's complicated. 18-year-old hasn't dieted, really obese, mum's obese. They both work at McDonald's. It's a very difficult cycle to start. Difficult cycle to disrupt. So what are your thoughts about that sort of patient?
Yeah, that's challenging. That's challenging. I mean, as much as I like to want to help people, but in that setting, somehow you have to, I guess, empower the patient to want to help themselves. So I might move the maxillomandibular complex 12 mils forwards, but in someone her size, that she's probably still going to have sleep apnea afterwards, and she's a high risk of relapse and failure. So the first thing she needs to demonstrate is that she wants to help herself by losing weight.
Yes.
And that's, I don't have a real cutoff, but for example, some hospitals won't operate on someone who's over 120 kilos in a lower acuity hospital. And they'd probably need to institute a strict criteria to say, well, if you, and same with, for example, lap band surgery, you need to demonstrate you've lost some weight, you've tried, and you've seen a psychologist, and you've seen a dietitian, you've exhausted everything you possibly can. So it doesn't sound like she might like the idea of it, but it doesn't sound like she's made the efforts to try and change her life. But in saying that, if she's class 3, then she probably would be a candidate for surgery if it was still an ongoing problem. Yeah.
Okay, thank you.
Well, thank you, everyone. If there are no further questions, we might wrap it up there. Edward, I just wanted to say thank you again for your valuable time tonight and a most enlightening presentation. To everyone else, thank you for tuning in, and on behalf of the Dental Solution and Respiratory Dental Institute, thanks for joining us tonight, and we will be having more of the webinars next month. Thank you again, Edward. Thank you. Speak soon.
Thanks a lot.
Thanks,
everyone.
Edward.
Thanks.
All right. Thank you.
See you later.
Bye now.
Bye.
Edward?
Yes.
Oh, one last question.
Yes, sorry about that. I was just thinking, with it being such a major surgery, do you actually advise patients to go and see a psychologist about the procedure they're going to have and, outcomes, and to get their head around everything?
I'll be honest with you, I don't in every situation, but it's probably something that we should.
Mhm.
It's one thing I wanted to institute when I was in Christchurch, because I had a patient, not an OSA one, who underwent surgery, and arguably a lot of these patients, they're young, and even the 18, 19-year-old, they're not of necessarily, they're of sound mind, but they're not mature enough to appreciate what's actually ahead of them. And some of them have actually almost like a, can't remember the term, not a body dysmorphia, but like unable to cope with the new changes. And I had one lady, had a much more balanced profile, and aesthetically much better. Functional occlusion was great, and she couldn't cope, and became depressed, and was admitted to hospital for like 3 months. So you raise a very valid point, and especially for an OSA patient, I would certainly encourage it, because one of the risks is that they may look worse afterwards, and that's something that I guess they have to consider to balance out, well, what's the functional benefit? But in the few cases I've done in the public system, I've always involved psychologists, dietitian, speech pathologist, as well as social worker, because a lot of patients I've treated have financial constraints, and they need extra help afterwards, and so it becomes a massive multidisciplinary type approach to it. So
everyone's got to be careful nowadays because of legal and ethical and everything else. You just got to be careful.
Yeah. So I think if I was to do more of this surgery, especially in the private setting, I'd want a team together with sleep physicians, a dietitian, psychologist, oral medicine, and just, work together, I guess. Yeah.
Thanks for the night. It was very interesting.
Yeah. Cool.
Thank you. Thanks,
Thank
Edward.
you. Thanks,
Good night,
everyone.
all.
Good night.
Good night.
Bye.
Bye.
Thanks, Ed.
Thank
Thanks,
you.
Edward. Bye.
Bye.